Imagine a man, 71 years old, recently retired and living exactly the life he spent 40 years building. He's sharp, he's active, he's still the first one out on Saturday morning mowing his own lawn, and he never misses his Tuesday night poker game with the guys. His independence is his pride. But then, his wife convinces him to go in for a routine physical he's delayed for 2 years. The doctor looks him over, smiles, and says, "Everything looks great." But then come those 6 words that change the trajectory of his life forever. "Let's just run a few tests." Fast forward 3 months. That same man is lying in a hospital bed, struggling to recover from a procedure he never actually needed, for a condition that was never going to hurt him. He's now battling complications that have nothing to do with why he walked into that office. The version of himself he had before that appointment, the lawn, the poker, the freedom, it's gone. This isn't a rare medical error. This is a systemic trap with a specific name in medical literature. And today we're going to look at it through a lens of brutal honesty. My name is Dr. Cartier-Cohen. I am a physician specializing in cardiovascular health and the science of aging. My focus is on how your body's internal plumbing changes after 60, and why the standard medical advice you've been given might actually be your greatest threat. In my work, I see this pattern every single week. Vibrant people who walk into a routine checkup feeling perfect and walk out as patients for the rest of their lives. Once you understand the mechanism behind this, you will never sit in a doctor's office the same way again. Here is the number that should stop you cold. Research suggests that up to 25% of all medical procedures in the US are entirely unnecessary. But here's the part Dr. Cartier-Cohen wants you to remember, that risk skyrockets the moment you turn 65. Not because you're sicker, but because the risk-to-benefit math shifts. The medical system, with its 15-minute appointments, isn't designed to do that complex math for you. We call it the diagnostic domino effect. One routine test finds a tiny, meaningless abnormality. That triggers a follow-up scan. The scan suggests a biopsy. The biopsy leads to an invasive procedure. The procedure causes a complication. Suddenly, you are managing a medical crisis you didn't have before you said yes to that first test. The tragedy doesn't start with the surgery. It starts with the curiosity of the first checkup. Today, I, Dr. Cartier-Cohen, am walking you through 5 specific medical checkups that I would personally reconsider after 65. I'll show you why the math changes and tell you the stories the textbooks leave out. Stay with me through all 5, because number 3 is the most common sense test that backfires. And number 1? It's the checkup almost no one is brave enough to question, even though the data is haunting. Before we begin, do me a favor, drop your city or state in the comments. I, Dr. Cartier-Cohen, read every single one of them. This community is becoming a global movement for informed aging, and I want to know who is standing with us. First, you must understand a concept I call the longevity lens. When you're 50, screening is an investment. You find a problem, you fix it, and you buy 30 years. But after 65, many conditions the tests find are indolent. They move so slowly they will never produce a symptom. In most cases, you will outlive the condition. But the medical system doesn't have a leave it alone button. It only has a treat it button. And once that button is pressed, your body's tolerance for intervention isn't what it was at 50. A procedure that a 58-year-old bounces back from in a week can cost a 73-year-old 6 months of their life and their independence. Number 5. Routine PSA prostate testing after 70. Precision matters here. I, Dr. Cartier-Cohen, am not saying prostate cancer isn't real. I am saying that for a man over 70 with no symptoms, the PSA test often tells a story that ends in regret. You can detect a tumor that is biologically sleepy, it's barely moving. Left alone, it would never spread or shorten your life. You would die with it, not from it. But the moment that lab report shows an elevation, the machine starts. Biopsies, radiation, hormone therapy. I think of Raymond, a 74-year-old retired electrician. Active, fit, 0 symptoms. His routine PSA was slightly high. He was talked into radiation for a slow-moving, low-grade cancer. 8 months later, he was struggling with chronic fatigue and urinary urgency that fundamentally changed how he lived his days. He told me, "I felt better before they found it than I do now that they fixed it." If you're 70 plus, Dr. Cartier-Cohen believes the question shouldn't be, "Should we screen?" It should be, "What would we actually do if we found something, and is that treatment worse than the disease?" Number 4. The bone density automatic pipeline. Osteoporosis is a serious concern, but we have to look at the automatic med trap. A DEXA scan shows low density, and suddenly you're on bisphosphonates like Fosamax or Bon-Eva. The message is simple: pill equals protection. But long-term use of these drugs, specifically beyond 5 years, is linked to atypical femoral fractures. Stress fractures in the very thigh bone you were trying to protect. Here is what isn't in the commercials. The most effective way to prevent a fracture isn't a pill. It's fall prevention. Balance training, like Tai Chi, can slash your fall risk by 50%. Most pills can't touch those numbers. Dr. Cartier-Cohen, saw Gloria, 72, develop an agonizing stress fracture in her thigh after years of taking meds she was told would keep her bones strong. She had never even fallen. Ask your doctor for your actual fracture risk profile, not just a scan score. Number 3. Routine cardiac stress testing without symptoms. This sounds so responsible, doesn't it? Let's just check the heart. But in people without chest pain or shortness of breath, these tests have a false positive rate of nearly 40%. That false alarm sends you to a cardiac catheterization, a tube threaded through your wrist directly into your heart. Now you're at risk for bleeding, vessel damage, or a heart event triggered by the test itself. If they find a partial blockage, which is normal for a 65-year-old, you get a stent. But the landmark ischemia trial proved that for stable patients, stents did not reduce heart attacks or extend life more than walking and medication. You get all the risk of the surgery and years of blood thinners for no statistical gain. If you're following this logic, type the number 3 in the comments. It lets Dr. Cartier-Cohen know you're seeing the pattern. Number 2. The carotid artery ultrasound silence. Hardly anyone talks about this, and that is a tragedy. This ultrasound looks for blockages in the neck to prevent a stroke. But the surgery to clean out that artery, a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during the operation. For asymptomatic people, the risk of the surgery often outweighs the benefit. Dr. Cartier-Cohen advises that your energy is better spent managing your blood pressure, the real stroke driver, rather than risking a surgery to fix a silent blockage that's been stable for a decade. Number 1. Routine colonoscopies after age 75. This is the one no one wants to challenge. But after 75, the risks get very real. Bowel perforation, a literal tear in your colon, happens in 1 out of every 500 scopes. In a 77-year-old, that means emergency surgery and potentially a colostomy bag. Then there's the PrEP, the liquid that clears you out. In seniors, this can cause dangerous dehydration, kidney stress, and electrolyte crashes. Dr. Cartier-Cohen, remember Margaret, 78. Clean history, no symptoms. Her doctor insisted on a scope. The PrEP hit her so hard she was rushed to the ER with critically low electrolytes and heart strain before she even made it to the procedure. She spent 5 days in a hospital bed because of a test for a cancer she likely would have outlived anyway. The Cartier-Cohen Action Plan. Next time your doctor suggests a routine screening, Dr. Cartier-Cohen, want you to have these 5 questions ready. What is the false positive rate for someone my age? If this finds something, what are the realistic treatment options for a senior? What is the procedural risk of the follow-up treatment? What happens if we simply monitor this instead of intervening? Is there a non-invasive approach that provides the same benefit? Any doctor who is truly in your corner will welcome these questions. Within the next 30 days, Dr. Cartier-Cohen, want you to take one note card and write these questions down. Bring it to your next appointment. You don't have to be a difficult patient. You just have to be a protected one. There is someone in your life, a sibling, a spouse, a friend, who needs to see this before their next physical. Send them this video. Next week, I, Dr. Cartier-Cohen, am diving into the specific medications that change their personality once you hit 65. If you take more than 2 pills a day, you cannot afford to miss that video. Leave a comment below. Have you ever had a routine test lead to a cascade you didn't expect? Your story might save the person reading it. Take care of yourselves. I am Dr. Cartier-Cohen, and I'll see you next week.